the more research we have and the more we know about these GLP-1s and their anti-inflammatory effects, right? All of the other things in which they're beneficial for, that it's worth looking into research on these younger demographics where I really do believe we'd see a greater cost benefit. Because I would like to see us expand coverage for pre-diabetes, obesity, maybe a criteria, right, for that, and PCOS, some things where it's showing that it's an effective treatment for those as well. So
that also
all those conditions you mentioned,
sorry.
just to finish,
Yeah.
are on there's research ongoing currently, so you are correct.
Yeah, no, I've seen some of the kind of promising, like,
Addiction,
preliminary
Alzheimer's,
things.
yes.
Yeah.
And when we talk about mental wellness and health within the education field, we are an obese group, and like your self-identity and feeling good and being able to be more active, like that all then filters into a healthier work environment. That's my 2 cents.
Appreciate the feedback. This slide, I just want to spend a quick second to just highlight that point solutions is not an end goal or decision by itself. However, there's utility and value from it, and it's and as a physician, I'll say, as a physician within the medical system, there's only things that we do well, and it tends to be when you are sick, to be honest, right? So I assess, I diagnose, and I prescribe.
Yeah.
I actually don't treat patients in the lab. So there's a lot of things around care that don't conform to an office visit that's only 10 minutes long. Point solutions can help round that out. So either it extends the care aspect of it for condition management, or in the case of addressing the shift left phenomenon, where some of these things we need to think about addressing before it is actual diagnosis or illness, means doing things outside before and independent of a doctor's visit. So we look to point solutions to do some of that. And the example I listed here that we made decisions last year include GABI. So improving breast cancer screening, the U.S. Preventive Task Force, is a goal. We're tracking that through MODA and as well as Kaiser. But for women, they need to understand their health risk, because the moment that they have higher risks, they go off track from the U.S. Preventive Task Force. But until you know your risk, you won't know that. So all the anecdotes of a young 30-year-old that happened to find early cancer, they possibly were high risk. So we need those risk factors. So GABI helps with self-advocacy, provides that risk information. So that was worth sort of a decision that a CL recommendation to the board, and the board made that recommendation. MIGHTY to improve the weight management, VERTA to provide a diet-centric approach to diabetes reversal, and then PREDI and OMADA for the DPP program for diabetes. So these are the ways we get to it, and obviously part of CL's role is to evaluate that, provide that feedback to OM. So those are the tactical things that get done after we make some strategy decisions about what we want to prioritize. Next slide. So with that said, there's 2 parameters if we want to proceed in an informed manner. Not moving forward? Okay, that's fine. So it's page 41 in the book. So obviously understanding the demographics and where meeting the individuals where they are at. Obviously the population, our educators are a majority women, so the women's health aspect is important, and Christy will kind of go into that a bit. But then looking at the clinical data, I will sort of dive into. We took the claims history and put a clinical lens to understanding how did those utilizations happen. Are there any clustering that allows us to better understand? So to the earlier comment this morning about not relying on averages, right? So averages is terrible. It means half are too high and half are too low. So we don't even know the exact thing. Whereas my statistician teacher used to say, you can cross a river that's 3 feet deep and still drown, right? So it's not helpful for strategy. It's useful for tracking, not for strategy. So I will dive into some clinical areas later today. With that said, next slide, and Christy, do you want to lead us through the women's health section?
Yeah. So as Dr. Twain just shared, based on OEB's demographics and previous in our packet, it was like page 26, just some of the environment that's around OEB, as far as issues and challenges that are facing educators and assistants and staff. one of the focuses could be looking at women's healthcare. And it does really fit the criteria of being achievable, impactful, and informed, as you'll see with some of the data today. One thing to keep in mind, though, too, is that a lot of the challenges that are facing women in healthcare show up in a lot of the different data points, because there's a lot of different ways that it kind of shows up. So, we don't have like a women's healthcare data slide, but you can kind of see, and as we look deeper into that data, looking at gender within the data, you certainly can see the impact. And so the circular graphic here is just really to give that comprehensive view of women's healthcare. There are definitely components that impact and, societal. A lot of women are mostly in that caregiving position. A lot of times, caregiving for kiddos, aging parents, and so recognizing there's all of this. Oftentimes women are also doing the family health decision making. There is some bias in our system for sure for women's health as well. Lots of research that, prior to, 10, 15 years ago, women were not always included, and then also some disparity. So keeping in mind it's really comprehensive. On the right here is just really talking about some of those areas that are impactful for focusing on women's health. And we've really highlighted two key areas there in those bigger boxes. And I'll talk about each one of these. One other just interesting data point I wanted to share is that, we do know from like the literature and surveys, and we even see this in like the Oregon Teacher Survey, that women tend to spend 25% more time in poor health. Or experiencing, we know there's increased anxiety and depression amongst women as well. And again, bringing that back to why it's so impactful for OEB and the educators, because we are 50% women. And so if we look into the next slide, I was going to talk a little bit more about menopause support and then family planning and caregiving support. And so with menopause, the big M word, in the last few years, we have really seen organizations focusing more on menopause because it does have such a huge impact. And there's support that organizations are offering. And a couple things I'll just say here is that menopause, oftentimes we hear about the vasomotor symptoms, which are, hot flashes, night sweats, those things, but there's so much more to it. There is, again, there's increased mood swings, anxiety, depression, loss of concentration, decreased libido, physical changes, weight gain comes in here. And also there's a big impact on musculoskeletal health because of the decline in estrogen. So again, just recognizing it has very far-reaching impacts, and it's so much more than hot flashes. And so we are really seeing that organizations, as you can see here on the right-hand side, there's just different support options that are available. One of those is really breaking down stigma and having communications about it. There's also within health plans, having access to certified menopause practitioners, which there is a certification for that, to have somebody who knows about hormone replacement therapy. And then it's also looking at affordable coverage for hormone replacement therapy, having education about all the different types and how you can apply it. There's lots of components there. So some areas that we're seeing organizations do a deeper dive and offering some additional supports to their members. And then also on the next slide, if we talk more about family planning and caregiving support, this is another area that could be really impactful for OEB. And this is even broader than women's health. Yeah, oh, sorry, I can't see, sorry.
No, thank you. So I want to congratulate the board, and I'll tie it back to the previous slide. When we added the doula service and we discussed it last year, I had two of my members saying thank you, but also the AFD nurses from Kaiser also reached out to me and said they were happy to see OEB acting on behalf of their membership and the public. But as a male, I was, that's common sense. Like, I don't see what we wouldn't be having that. And I see on slide 43, the menopause support, I see the increase on, watching in the data and then the employer support options. I just want to put in the room that based on, in my own personal experience, I guess, it's like I can't speak for women, right? As a male, strict male, I think that when we speak to equity, gender is important for me because majority of my members are women. I have a daughter, society depends on them and many things, right? I just want to make sure that I put it in the room that whatever we need to do to help women in the environment, whatever supports we need to increase as a board or communication, I think we should do. I don't think we should wait for the board to have a motion or we need to support for the board to take credit. We should, but I just want to put on the room that we need to be more proactive as we've seen some data that there's a retirement in the age in the field. So I don't want this to be an issue that we could have prevented or we could get ourselves ahead of it. So this is the year for us to put more emphasis on this, I guess, medical condition, doctor, I don't know, or this phase of life. I think we should, just like we talked about breast cancer last year, right? So I think we should also put as an effort on our radar at the top.
Thanks, Rudy. And I mean, what you said is so great too, because it's such a recognizing that while we say it's women's healthcare, it really is everybody's healthcare because we all are connected and it impacts all of us. So. And then so family planning and caregiving support, very similar, obviously, again, it doesn't, and even it impacts all members. And again, very comprehensive what we mean when we say family planning and caregiving support. You can see here it goes, again, it starts, sexual and reproductive health, family building, pregnancy, doulas do fall, kind of under this category. And then even, parenting, child health, and then again to that caregiving role. So it's an impactful area that a clinical strategy could be developed to really start to look at the different areas here and be able to act upon. One thing for OEB right now is having the family forming benefits and including coverage for artificial reproductive technology, which would really allow for an inclusive benefit. I think, Ian, I'm going to turn it back over to you to talk about some of those more top condition data points, unless there's any additional questions.
Okay. So we're going to extrapolate from some of your history from the claims data and the time period. So this is a bit of the technical stuff that frames the quantification that we'll go through. So we're looking at a 12-month period, as reflected here, May 2023 to April 2024. And some of our comparisons are the previous years. So 1 year prior and then 2 years prior. Keep in mind that the 2 years prior includes a bit of an overlap with the COVID. So take that with a grain of salt. And then the concept of episodes. So we try to get fancy with the analytics. So the episode just looks at cost and identification of individuals in a way that if you just see sort of a random diagnosis, was it just a coding, just somebody needed to be seen, they put that diagnosis in and they moved on. So there's logic that basically ensures that there's enough cookie crumbs in the data to say, hey, they really did have this condition because they saw multiple providers or they received care that are all relatable to that diagnosis. So it's a way to make sure the count's valid. That being said, when we're talking about identification and prevalence, because we're using claims, it means we're identifying based on people who use services, those that didn't, either because they had difficulty with it or they're still relatively healthy and they didn't need attention, we don't see them. So just keep that in mind. So we tend to undercount condition prevalence. Okay, next slide. So when we do some grouping, they kind of fall into these three categories. Starting from the far left, based on spend, these kind of came up to the top because of total spend. And we'll profile some of them like pregnancy and diabetes. They tend to be sometimes and often smaller in number, but the cost of care tends to be somewhat higher, and that's why they fall into the spend. If you go to the far right, based on member impact, this is about the quantity or number of individuals that were impacted strictly. So these are higher numbers of relevance from a member count perspective, and they're listed there, the top 4. And then you have a middle section, which is a combination. They are enough prevalence, meaning there's enough members that have sought care for these conditions, and part of their care or treatment, from a cost perspective, added up enough that they kind of rolled up. So this is the intersect of both. And you notice that these tend to be those that are people seek care, what I call symptom-driven utilization. Right? So we'll talk about some of the potential drivers of why those conditions are in that bucket. Questions on what's kind of trickled out? Any surprises? Things you weren't expecting to see? Yes, Michelle.
I'm surprised that depression and anxiety would be high spend.
So it's because that's the intersect. It's when we get to that section, you'll see it's a combination of there's enough individuals seeking care for that, and plus the numbers of service. So it's a multiplication factor.
Okay.
Yeah, and we'll break that out into those units.
A question.
Yes, Enriquez.
Is the maybe it's not don't have data on or the answer on. So we talked about wellness last year. I mean, and mental health due to the stressors and the education field as educators. Is anxiety and depression linked to work or like work-related stress, or is it just just in general? I guess I was wondering if you have that.
It's a categorical. It's general. Within this level of insight, we don't have the underlying drivers of those symptoms. It's just these people sought care, and these were the diagnoses that were registered for those services.
The national and Oregon teacher surveys, though, both link anxiety and depression to work-related stress and burnout. So we do have that anecdotal connection.
It's not existing.
And on that point, because this is on slide 26, we did pull out, this is a very interesting fact in that regard, because for teachers, 59% report, and this is a national survey, 59% report frequent stress, while for the general population it's 33%. So I think that kind of helps to kind of understand.
The superintendents there would be 90.
That's even higher, I guess.
60% sounds great.
Well, and I think just one thing I'll add to that too is I think oftentimes, again, going back to the wellness and teaching, having resources and skills where when you start to have that kind of stress and burnout starting to develop, that you have the resources in order to at that point intervene at an earlier time versus having it kind of, keep going and then it can develop into a diagnosed condition.
Yeah, we see it every year. I mean, even in a district my size, every year a teacher will burn out and just be done with the profession. It's tragic.
Okay, so for the next sections, we'll kind of dive into each, a few of the key ones. The next slide will be around maternity. So that was the one that hit number 1 based on spend. And if you see these numbers, it's not large numbers, right? So pregnancy, there were in the plan year, only 1,833 mothers identified, and 960 newborn contributing to that cost. So we went through and sort of provided some metrics to normalize and give you a sense. So patients per 1,000, we just take that 1,833 and put it against 1,000. It's an industry standard, but basically it ends up being 1% if you do it in a traditional percentage. But it's 11.7 per 1,000 is the number of pregnancies. And in terms of ranking based on patient volume, it was past 20. So we just anything less than 20 on the ranking, we just put it greater than 20. However, if you look at the allowed total, it's accumulated to a total of 28 million 28.6 for the pregnancy-related care, and then the newborn was just about half of that at 13.7 million. And then if you normalize that to a per member per year cost, it gives you a sense of kind of what's the contribution margin when you spread that cost across all members in a year.
Does
Yes,
this
sir.
include all ages of the birthing parent?
I believe so, yes. There's no age filtering on this, no. Now, the trend year over year shows a -6 for pregnancy. So that may, be cyclical. You can look at it over time, but this one was just a 1 year sort of trend, -6 in terms of the number of patients, and that translated to a cost trend of -16%. That gives you a sense of how to look at the cost of care associated to the number one total spend. What we have in place, obviously, is we've got the doula support going on. This year we were looking at the traditional health workers and other things that come to mind. Just some notes here. McKenna medication that was previously a high cost, it's no longer covered, right? So there's evolving standards of care. So when we're looking at cost over time, we have to factor in sort of what was available to the clinicians, and also the type of maternity delivery, high risk versus C-sections, and all those things become factors. Okay, let's move on to the number 2 one, which is diabetes. So diabetes is a overall bucket, but the majority of the individuals here will be considered type 2 diabetes as opposed to type 1. And the quantity numbers of patients is 5,719, or it turns out to be about 36.5 per thousand. So it's around 4%. Epidemiologically across the U.S., diabetes sits around 12%.
Wow.
So we are, lower than national average. But again, keep in mind, this is based on those that are receiving care. So let's do a little plus minus there, still significantly lower, right? So diabetes type 2 tends to start onset in the 40s from risk factors that were onset in the 30s. Hyperlipidemia, things like that, obesity, etc. So when you translate that to your numbers around demographics of your educators, that's put that in context. Total allowed cost is about 22 million, and that translates to a per member per year average cost of 163. And it was ranked number 2 in terms of total cost. So what we have going on from an initiative, right? So diabetes is the endpoint of a part of cardiometabolic conditions. So the solutions that we have in place as of last year, you can see it's pretty robust in the sense that there's multiple entry points depending on where the individuals, the educators are, and what their perceived needs could be. So it starts from the very front end, if they're trying to just improve health and lifestyle choices, to all the way to prediabetes and diabetes. So the more sort of aggressive one, for lack of a better term, would probably be the type 2 diabetes reversal. So through tight dietary optimization, we can see, and we'll get those reports from DERTA, of individuals that reverse their diabetes, so their level of diabetes abnormality, high level of glucose, improves such that they could sometimes come off some of the medications. So it is possible, but it requires those individuals to be highly motivated and basically being controlled through dietary adherence. Less structured program, but still nutrition centered. MODA has as well as Kaiser through their respective programs. So we have different approaches that should align with different individuals' preferences or willingness to be proactive in terms of addressing these kinds of issues. Again, we will look at the reports and from the carriers and the vendors at the appropriate time and sort of dissect and see how well that's aligned. Questions on diabetes?
So one call out I'd say on diabetes, all of the allowed per member per year and the total cost
that doesn't incorporate the effect of any rebates that are coming back on the prescriptions. And some of the categories of drugs that are used in diabetes, they do generate rebates. But we don't get data to the level that allows us to tie the rebate to the specific condition. So the allowed might actually be lower than this, but we don't have a good way to quantify the magnitude of that.
And some of the pharmacy comments include, obviously, again, we speak to GLP-1 in the context of obesity, but it is currently being used, and there's associated costs, and that's partly why diabetes is number 2. And it's not just GLP, there's another class called SGLT2s. So these are effective medications to not only improve the glucose control, but it reduces the cardiovascular and chronic kidney comorbidities. These are the downstream high-cost conditions that could come up. Again, this will take time for it to show benefit in the OEBB health plan, but right now we're seeing the utilization for diabetes, and the indications will continue to grow. Okay. The next one gets to some of the questions around behavioral health, and what we did was break it down to those 3 sort of main categories. Obviously, depression and anxiety tends to be more of the chronic, ongoing types of conditions. Substance use can be chronic, but then there's episodes of high intensity, potentially high intensity treatment, and we'll go into some of the data and utilization behind substance use care. But from a patient prevalence, depression was number 4 and anxiety was number 5. You see the total individuals that were receiving care for that. And you see the allowed dollar amounts and the normalized per member per year cost. So when you look at sort of depression relative to diabetes, right, all of a sudden you're in the same ballpark, and how they got there are totally different mechanisms. Right? That one is high cost medications. This one is ongoing care. Medications as well, but there's other factors at play here. And the trends for both patient as well as the trend for cost are both going up for depression and anxiety, as well as and less so for substance use treatment and care. So these are individuals receiving and seeking care, and but, obviously from the national survey statistics, we know that the prevalence is likely high. From a current ecosystem, what we have in place is relatively robust if you think of the solution. So I'm glad that member education came up as potentially a goal, because having the point solutions there is just step 1. If the members are clear, and if you look at the name, none of them are informative by themselves, right? So Gemini, I'm thinking rocket ships, right? No one's going to just look at that name and think, okay, that's a behavioral health partner that can help me with mental health. It's just not intuitive. So how do we connect the dots between open enrollment, where you list this as all these great benefits for them, to the time of need, which is going to be just in time, right? Healthcare is hard to educate for. It's going to be often just in time. Or my daughter says, if it's not on YouTube, I'm not going to learn it. It's like, oh, that's not a great way, but that's the generation. So how do we do that education where I have a need, right? Is it always just pointing them to, if you're on MODA, Behavioral Health 360, just go there, and then you'll be navigated through the appropriate solutions to help you. I think there's better ways, and there's improvement that is still opportunities for us. But just the set of point solutions that are there covers the gamut from mental health resilience, just trying to, when you need some service or some benefit to help you with development of mental health and mental health resilience, Headspace and Calm are there. To more acute care treatment like Hazelton Betty Ford or Spring Health. So we've got the gamut. So it's not from anything missing. It's about connecting individuals to what's available. Questions on behavioral health?
I was just going to add in just on the performance guarantees that we did, that are in place or going to be in place, right? This year that we did put in guarantees for appointment wait times, as well as geographic access points for urban, suburban, and rural. There's also a provider diversity metric that was included in there. And in areas, I think the first year is just a report out on where they're at, so we kind of set baseline. But then also, each of the plans need to have an improvement plan for one of the metrics that they didn't meet or that is a room for opportunity. So, so a lot of this is, again, going back to that access component is, it was a good first step on working on that.
Thanks, Chrissy. And that's a great segue to the next slide, which we took this to the next level, which is starting to look at any disparity and unusual patterns by geography. So we were moving past laws of averages, and here it unearths some interesting inconsistencies in terms of access and utilization. So if we look at the top, we kind of broke it in the high level urban, Oregon, and rural Oregon. And just that alone, you see some difference in terms of prevalence for anxiety and depression. Now, what we don't know is there more in urban relative to rural, or is it an access and availability? Right? So that's the next level of analytics. But then when we break it down further into the geography map from the previous morning session, coastal versus metro versus northeast, southeast, there's even further differentiation of prevalence patterns. So specifically, northeast and southeast, it's quite lower for anxiety and depression. So knowing the geography, knowing the prevalence of mental health providers, is this one more issue of availability? If we know that as educators, generally there is a higher prevalence of mental health conditions and behavioral health needs. So, but it is not even or equal across all geography. It's something we have to factor. And then when we get further down into sort of some of the various profiles around utilization, specifically coastal, you see the behavioral health out network. So there's a strong indicator of potential network gap. Because even though northeast and southeast we raised as low prevalence, only southeast was sort of moderately high in terms of out of network, but definitely coastal at 23%. It was factors over any of the other geography. So it warrants sort of an analysis and figuring out what resources do they have, what kind of access and availability do they have for in-network behavioral health care providers.
Andrea, Dr. Lauer had a question, behavioral health question. Which condition is ranked number 1 and number 2 on the previous slide?
So just within behavioral health, depression was number 1, followed by anxiety. And then substance use was further down, just within mental health. But they ranked 4th and 5th on the list of, yeah. Oh, got a thumbs up, good. Got the emoji. Other questions about this?
I was wondering, on our last request for proposals, the ones we were here, and we participated in the process, we selected certain companies were recommended and the board adopted. Maybe you're doing it a different way, but I was wondering if when we do another request for proposals before the study or for the process, we could get sort of a engagement of a summer service satisfaction from our members to see if we're going to keep that provider, or should we look into someone different? And also, because I see you highlighted Canopy and people have mentioned that was great, but we did I was possibly saw like, I don't know, 10 industry providers, and we kept few. So that's one for our future selves, so we can compare their service.
Misty, does the outer network in coastal, does that take you by surprise or no?
No, like Tillamook County, there's one mental health care provider. That's a big region, and it's Tillamook Family Counseling, and it's one stop, so that's right on target, I feel, in my world. Yeah.
Misty, do you think people, and it's perfectly reasonable, there's some, because we also have like Maru, for example, through MODA. So there's, and many mental health providers are just virtual anyway, because they went virtual during COVID and they've stayed virtual.
Correct.
So potentially there's enough access virtually. Where we're really missing is in person. Do you get the sense from members in your area that what they really are missing is in person, or is it more, I don't even know what my digital options are too?
Actually, I think it's both. I think based on age, they're aware of telehealth and like, you know, many of us practice virtual things like that. When you have an older component, which happens in coastal communities and educators, the tenure there is really long. So you have an older component, they're going to look for a physical space to go to receive that service, and then there's a lack of it. So that's membership education piece again, where you can tie your older component to the telehealth.
We're in between categories now, so let's take a 10-minute break.
Okay,
All right, we'll return at 1:45.
Yeah, we don't think about equity like this.
Yeah, I mean, they're great places to work in small districts.
It is, especially if people have different care seeking.
And different levels of digital.
Yeah.
It's on the mornings.
I understand what you're saying.
I wouldn't doubt it though.
I hope so.
Yeah.
Well, I'm sure Susan would approve putting her on the spot.
Oh man, that's the hardest gig.
Yes, and be interested, but the only complication is that, in our contract and our, I think there's only 40 hours of association reading in the district. Per member.
Still finally getting over it, you know?
Yeah, at that age, you're such a superhero, like you get all of this love and support. Yeah,
Little less
it's hard.
On to cancer.
Nice intro.
So we'll continue diving into a few more clinical areas. These, again, were ones that trickled out. So cancer ranking, just within cancer, the 1, 2, 3s are skin cancer, breast cancer, and cervical cancer. Now, with the caveat that skin cancer, not all skin cancers are malignant. And so there are slower growing cancers like basal cell carcinoma that's very common without falling under the cure. But in the aggregate, they're number one skin cancer prevalence. And it's about 3,500 individuals, and it works out to be about 2% of the population. So not super high. And the cost, you can see down below, is about $5 million. Again, breast cancer supersedes that because, again, the mix is slightly different when it comes to skin cancer, just from my own clinical experience from that space. Now, here's what's challenging. Breast and cervical cancer, there is U.S. Preventative Service Task Force guidance. Keep in mind that their guidance is for average or no known high-risk individuals. So the average population screening criteria are known for breast and cervical. And we have data about how well our population follows that. Skin cancer has no official U.S. Preventative Service Task Force, even though it's not that hard to just sort of check your rules and see if anything has changed. Because self and early identification, again, for all cancers, that's key. So we're supposed to, primary care, is supposed to do that as part of the wellness physical. But there's nothing to code when we do that, so I don't know when doctors do it or don't. When we talk to the carriers, they generally don't believe their doctors are doing it consistently. So that's a risk area from a prevention or a shift left kind of a construct. So with that said, I just raise it as something to potentially want to consider is there are sort of self-guided skin cancer monitoring tool in the form of an app.
That's OHSU.
Yes, one is right out of your backyard. The academics at OHSU has an app. It's free for the public to use. So if not for all educators, but definitely for the individuals in this group, it's a simple way to just track them all. Before we had a phone and a camera readily, this is how I had to do it. I had to describe it, draw it the best I can, and we had to do A, B, C, D, E documentation. Asymmetry, I can't remember now how to camera, but colors, the edge, and whether it was evolving. So there are ways to describe it, but it's nothing as reliable as seeing a picture before and now and noticing that, hey, this mole is changing over time. So that's what these apps can do. So it's a way, again, around self-advocacy, but it requires educating our educators and our members to do that. With breast cancer, I mentioned Gabby, that's starting this plan year. It puts in the hands of women to sort of do their breast cancer risk assessment. With that information, they can guide their conversation with their physician and say, hey, I need to not follow the U.S. Preventative Service Task Force. I'm higher risk. And that may be genetic testing, it may be early mammogram, it may be doing MRI testing, a screening for the cancer. But until you know your risk factor, the assumption is you're going to follow the U.S. Preventative Service Task Force. So those are things that are in, options of ways to equip our members, our educators to basically be more self-advocating and be more hands-on with their care. I will mention also when it comes to genetic testing for cancer, I'll just throw it out there. Out of OHSU, there is a funded study that each of you in Oregon can participate in. So healthcare, when you're asking about do you have more information, part of this is just sample size. Like getting more people in the data to understand the potential impact, especially impact of health diversity. Getting more women involved, more ethnic individuals to understand these factors. So there's a study looking at breast cancer genetic testing and screening. So if you are one of those that is curious, it's called Healthy Oregon Project. right? So, but your data becomes part of a pooled set of data that they will analyze and try to identify whether genetic markers can help you identify this.
I had that done. I've had breast cancer and they did genetic testing because I had sisters, and it was identical. The results I was surprised for free.
The big greater good, so
Yeah.
think about it. So with that said, let me pause there around cancer. Obviously, it's the numbers aren't significant, but we all know those who have had cancer, the care and the access, timely treatment and all those factors is important, but so is the screening and the prevention.
Is there any opportunity around cervical cancer prevention with the HPV vaccine for some of the younger members?
So we know cervical cancer, a certain percentage of them are due to HPV, human papillomavirus infection. So two things. One, we test now for the virus as part of cervical cancer screening, but there's now also a vaccination against HPV as well, yes. And that's one where it's not just screening, but it is prevention option as well.
We're only looking at skin, breast, and cervical, right? Like, why aren't we looking at the data on all cancers or other types? Just out of curiosity.
We pulled out the top 1, 2, 3
Okay.
within cancer.
Yeah, I was just wondering. So are those the most prevalent?
Yes, these
Okay.
are prevalence based on just within the cancer as a category, but you see cervical is quite low, right? So
Yeah.
it drops down quite a bit, with skin cancer being 2,500.
Okay.
It's not to say the other types aren't important or don't impact people too, it's just simply in the interest of time.
Yeah, I
This
was just
afternoon,
curious.
highlight the certain things.
Yeah, you're fine.
But if you want to know all the cancers, let me know, because we have the data.
I don't have anxiety. You have anxiety. It's fine. I don't know.
But you know, I like data, so any questions on data, let me know.
We did talk about some of the potential upcoming technology and testing for better cancer screening coming in the future, maybe, hopefully.
Well, it's available now, so there are concepts. So I was just at the National Academy of Medicine, so there is a test called multi-cancer early detection. And the brand is Grail. You've probably seen commercials for it, because that's how they've been having the market. So we can do blood tests that can look for cancer genes, genetic material from cancers that's floating in your circulation. So what we're trying to take advantage of is when cancer tumor sort of dies, their DNA gets shed. And then when it gets shed, it starts to go through circulation. So there's a way to take a blood sample and test for up to 50 cancer types. So when you look beneath the surface, here's some caveats. If your cancer is there, but it didn't shed at the moment you drew that blood, you won't find any. So it doesn't mean you don't have a cancer. So a negative test is not cancer-free. It just means we didn't find it. So that's important, number one. So some patients you can buy it yourself. It's about $900 if you pay directly yourself. So they're happy to sell it to consumers. But they have to understand it doesn't mean you're clear. So all these other guidelines are still important. The other important factor is we can potentially detect cancer earlier, but then I, as a physician, have to go find it. Right? When you have a symptom, it's kind of a pointer, and I look for cancer there. Finding cancer in your blood that's circulating around, now I got to go find it when you feel okay. So now I've got to do MRIs, I've got to do other blood tests, I've got to do other things. Based on what we know, it's only a 45% positive confirmation rate. So if you get a positive test, only half of the people we can clinically diagnose. So now you're left with the half saying, well, I got one positive test result, but I don't know where it is. I don't know what it is. So those are issues that come into play. So it's one of those things, the technology is there. Over time, we need people that are willing to pay for it to add data so we can understand it more. But until then, it's neither recommended by U.S. Preventative Service Task Force as a screening tool. And most of my clients have asked about it, but they end up not signing on board for it.
Leads to anxiety.
Anxiety and uncertainty and potentially additional tests. with no definitive answer, because how do you find something that you can't see? So a tumor this big could be shedding DNA that we happen to find, but I can't find a tumor that big very easily. Okay, next one. Musculoskeletal. So if you remember the Venn diagram, musculoskeletal came up under relatively high prevalence, but then the treatment cost, because it includes surgery, which tends to be expensive. But we profiled it by a number of conditions. So we have it by joint disorders, which is basically diagnosis codes that involve joints, knees, hips, shoulders, etc. Low back as its own separate category because it's common enough. And then other back disorders on the far right, other than low. So that could be neck or thoracic, upper back, basically. And then osteoarthritis is basically that degenerative condition where your joints start to deteriorate. So it's a very broad category. And often it ends up being sort of a surgical in terms of treatment or expensive medication. So with that, you can see sort of the prevalence. A lot of joint disorders, followed by back. And back is both low back pain, but also other areas of the back. So these tend to be chronic conditions, right? So if there's some abnormality, chronic symptom, these are symptom-based kind of problems initially. They're going to lead to people seeking care, looking for treatment, and treatment could be medicinal, or in some cases, surgical, specifically joint replacement as the most common joint procedures, and low back pain through fusion. Now, we're probably doing too many surgeries than we should, especially for low back. It's a very intricate area, so when you use that back, it's a one-way street. The assumption is that cured your first problem, but we may have created new ones. It's common to have secondary problems from the surgery. Now, chronic conditions that are musculoskeletal in nature persist over time, but there's opportunities to improve the symptom management. So you notice on the right-hand side some of the available services that we've provided. We've got complementary and alternative treatment as an option. It came up in our discussion group, so things like chiropractic care and acupuncture. When it makes sense and when it's effective for that individual for managing symptoms. For more hands-on, traditional Western medicine approach, we have SWORD, which provides a physical therapy approach to care in the convenience of your home through digital app. Right, so physical therapy typically, at most, you get 3 appointments a week, and you have to go to see them, and it's for a defined time. But we could appreciate that musculoskeletal types of things could benefit from ongoing, repeated treatment and management. So the digital apps like SWORD bring that to you in the convenience of your home. Because a lot of this is just some of the range of motion types of exercises that you can do in the convenience of your own space. So let me pause there. Any questions about musculoskeletal? MSK.
Is this any particular like gender or age group that we should start thinking about now that could be potential like, well, in 10, 15 years, we're going to have a high number of people with lower back disorders because 25% of our population is veteran and due to the service-connected disability and they're in the field. You see what I'm trying to get?
Yeah, we did not profile it to that next level. We should have that data.
Oh, sure.
Yeah.
I guess more thought for us to just think about moving forward, what can we catch now for certain designing policies or the system with Motor and Kaiser, or how are you tackling this so it doesn't become a chronic issue?
Yeah, and I would throw back the question for consideration is also where and how can OEB influence the entities, right? So for your educators, they're spending 1/3 of their time at the workplace, which is the schools or our education facilities. So much of this is tied to just how do we conduct ourselves during the day You know, you stood up to just stretch, and it's good to stand up periodically because we sit too much. So there's things like that, how do we make that okay and the norm and acceptable to support and to augment whatever we think we can do from a program point solution. Because this is kind of like pharmacy medication. You can't prescribe our way out of it. These things help, but there's other factors that contribute to it. And ironically, MSK, there's also strong correlation with poor sleep and other things, right? Because one leads to the other and vice versa. So there's cluster. You can see that in the data.
There's relationship to the cardiometabolic spectrum too,
Yes.
right? Yeah.
And depression and anxiety.
Yes. When you're chronically having symptoms, obviously it wears on you mentally. So there's a factor of mental health. But then the reverse is also true. If you're dealing with some behavioral health symptoms, you're not going to have any energy to try to address the physical side.
Thank you.
Hope I'm not being a downer on some of these, but I think these are just, you know, the realities and the opportunities are there. They're not simple solutions. Again, you can't prescribe or medicate our way out of some of these things. The next one is interesting that it kind of came up to the top, which is 2 conditions related to the skin. We've got skin infection and skin disorder. So skin infection is, you know, what you would expect. Cellulitis, insect bites, things like that, fungal infection, that kind of stuff. Skin disorder is a little broader because it includes some of the autoimmune-related skin conditions like eczema, atopic dermatitis, psoriasis, and things like that. So you notice that skin disorder, from a ranking in terms of prevalence, is well below 20th in ranking. It's only 735, but they're contributing $12.8 million of cost. And that's because there are biologics or immunologic medications. Again, just look to your TV. Whatever's being advertised are the ones that are selling well. So they're your Skyrizis, they're your Dupixent. They're expensive, but they do a good job of managing moderate to severe psoriatic dermatitis. So that's contributing to a large part of that cost. And the medications are listed below. You've got Taltz, Skyrizi, Stellar, Dupixent. You've seen those commercials, right?
And once you're on it, then you're on it forever. It's not like corrects the situation. Is that right? It's just treating the symptoms?
Yes, they do control. So they're indicated for moderate to severe. But moderate to severe is very loosely described, right? It's when your symptoms are bad enough, then there's ways to measure that. But they do carry some risk, right? So the disclaimer when you see the commercial is let your provider know if you've got infections, tuberculosis, and things like that. Because it's an immunologic, it suppresses your immune system. So it does put you at risk for catching other infections, or when you catch an infection, you know. So there's a certain percentage that end up coming off of it. We see that in the larger data set. We have not looked at your data set in terms of how many people are coming out.
People that are coming off tends to be for side effects. It's not like they achieve the clear skin and then they come off. Typically, they do continue on it to maintain maintenance unless they can't tolerate it.
Okay.
Are insect bites really high on the list of skin infections?
So, you know, the conditions that fall in that middle on the Venn diagram tend to be symptom driven, right? So they're the ones that your child or the adult just has a symptom that has to be looked at or addressed. So yeah, it could be anything from insect bites to skin infection, nail infection, fungus. Yes.
Childhood warts, probably a great one.
So, you know, which brings up an interesting point, right? So even though there's no list of point solutions that is pinpointing for these conditions, the availability of easier access, right? So when we're talking about cost and out of pocket, going to the ER for what may be symptomatically impactful, but it's not emergent, is costly to that member. But that may be all they're familiar or used to going to. but it has a cost in terms of out of pocket. How do we create awareness that there are these virtual care options that are lower cost? And if it's for these kinds of conditions that are not life-threatening, you're not, not to pass out, you're not going to lose your breath, it's not anaphylaxis, but it does require somebody to just, by guidance and potentially prescribe, to go to those lower settings, because it is a lower out-of-pocket potential. But so the good news is your ER utilization is not crazy high when I looked at it. I've seen worse in terms of other groups. That's good news. What I don't know from a correlation is because we do have virtual telehealth service access available. I did not look for temporal correlation, but we do have that. So how do we, again, back to patient education and making them do that connection, because until you have that child that's prone with a huge redness, that's the time when they need to know what are my options. Okay, next one. Again, this one is symptom driven. It's everything that's sort of up above your neck. Sniffles, runny nose, coughs, all those things fall here. And you know how prevalent that is, especially in the time and attention that's needed, especially if you have children that need to either have that looked at, treated, or get that note so they can go back to school. So the drivers of that are high volume, 10,000 to 18,000 for anything related to the ears, nose, and throat, basically. Ears are excluded in terms of the ear infection, I believe, in this. But included in this are some of the higher medications. So for asthma, as an example, there are, again, the immunologic medications now that work better than just the simple inhalers. Xolair and Dupixent are two of those. They're also expensive eye drop medications for chronic eye irritation, eye dryness, those kinds of conditions as well. So this is one of the categories of high volume with relatively high cost of treatment options, driving the overall ranking of these conditions.
And this is another category where there might be opportunity to look at the site of care, like the emergency room versus, is it telehealth or?
Yep. Yeah, if it's, I just need to know that my child is clear to go back to school. The emergency room is an overpriced setting of care to get that note.
And even differentiating further between emergency department care and non-emergency department care, there's still the choice of specialist versus primary care in office setting versus CRSMD. And we learned in April of last year at one of our board presentations, the visit cost now for CRSMD is $55 a visit, which would be by far the lowest cost option of all of them. So it ties back to member education and helping members know, hey, this should be my first line of defense for truly non-emergent situations because it's going to be most affordable for me.
This was the category we were looking at, and we were surprised by how much ER utilization there was for EMT.
Doctor, I have a question, if I may, and maybe this is different for different people, but as we were talking about early on, when someone discussed the 4.5% about the cost of the revenue and how much money we have available. And I'm looking at these numbers and the dollar signs, and we talked about preventative healthcare last time around, and I'm thinking, well, inflation is going to continue to grow, so I'm feeling that healthcare is going to be more expensive as we continue to, I guess, age or develop. So I was wondering, when it comes to the healthcare piece, what can this for? What can we do in addition to like physical fitness? Like, what do you think we can do to lower the cost? I guess at the individual level, like what program do you think we should be emphasizing? Like more PT we should make that part of the culture. I guess where can we have control of what do you, I mean, that's a maybe different question, I don't know what I'm trying to say.
No, I get it, yeah. If I had a magic wand, it was all up to me to decide, I would have a different answer at 3 levels of the care continuum. Starting with how we access care, right? Just, there's a difference in terms of cost to the plan as well as the individual based on where you go. Obviously, the ER is the most costly, and there's a role and a place for ER, but then there's alternative all the way through virtual care, where if you are in a rural community and you don't have that easy access to a CVS, convenience urgent care center, then the telehealth or virtual care is a valid way as a point of entry and to get that assessment, diagnosis potential, and recommended treatment. So that's just a savings from a diversion from a more efficient, from a high cost to a more efficient level of service. The next one gets to, okay, if I have to receive care, what are my options? So that's where some of these point solutions can bring value, because it becomes digital, it becomes remote, and it's outside of the physician or the caregiver's office. It could be PT, it could be a physician or anyone else. Now it's in your hands, but again, it requires that individual. So the first one, they need to understand not everything needs to go to the ER, but then they need to know what the alternative. The hard part is we tell them, you're overutilizing, stop going to the ER, but we don't explain to them where the alternative. Now the treatment is, well, you don't always need to go to PT. We have options, and this may be more beneficial because you get more repeated treatment options, not just one Monday and Friday. So that's the care options there. And because it's a point solution, it's actually zero cost to the individual, as opposed to going to a PT or a chiropractor. Then the third one is the proactive prevention and early care. This is the hard one because the other two are symptom driven. And when you don't feel well or you feel something is not right, there's an easier, more compelling drive for you to do something about it. This one is, well, I don't feel sick. Maybe my lab is abnormal, but I don't feel anything from it. Or I don't think I'll get the cancer. All of these become necessary preventative. The preventative, I find, is always the hardest. It always makes sense when they nod their head when I communicate that to my patients. But to get people to act on it, you really have to reduce all those barriers and create a compelling reason for them to act on it. So those are the 3 buckets, as I call them. The education has to be different because one is more tangible. They feel it right away. The second one is, okay, I'll buy into it because we're going to try it. The third one is, I don't even think it matters to me. And the reality is it may not, right? So when you're doing prevention, it's statistics. 1 in 100. We gamble with much worse odds than 1 in 100. But for 1 in 100, it's like, it's not me, it's going to be somebody else. Right? So from a plan, I need 100 people to do the same thing to help that one person. Because I can't say that just because you did something and I actually prevented a disease for you. If I have 100 people like you, yes, I'm going to find that one and I impacted that one. No,
I'm good. I'm just trying to think of, like, I know we're going to have genetics conditions, but you know, certain things are on us, and I'm not the best one to speak about it.
And hopefully that will inform the tactic, right? Yeah. Tactic is where it gets hard because it's not one size fits all. It is partly depending on you all, because you understand your colleagues and your peers the best, and your locality and the constraints and all those other factors that I hear about it, but I don't experience it the way you guys do. Which leads to the next section, which is, you know, we've got some high level goals that we'll tabulate. And now we've got to align those goals with, okay, what areas are we going to focus on, align to those goals? And then the harder question is, well, what do we want to think about doing about those? And sort of charge us to work through the homework to provide that information to inform you guys on what's doable, what are the options.
The goals is all putting them on a slide Emily will bring up and you guys can see.
Can we go there now?
Yeah, let's do it, and then you have the goals going into the tactic conversation. Pardon the delay. There we go. Yeah, so member education came in at the top, #1 goal with 9 votes. And then the other 4 goals were all tied with 6 votes. And we were able to get Dr. Lara's votes as well, even though she's virtual. So goal #2 would be grow OEB. Goal #3, explore an RFP. Goal #4, we rephrased just a little bit as provide equitable access to affordable care, which maps to option C and group #2's board over there. And then goal #5, reduce out-of-pocket costs. Just to clarify we still have a renewal process where we ask our carrier partners pretty much whatever we want. These goals give our work in the public board meetings a lot of focus and direction and help us decide on the tactics. And also, we still have the flexibility to ask other things in addition to. So I don't want people to feel like something that they had was really passionate about and didn't make it on the list. We'll still work to simplify the CCM through the renewal process, for example. It might just not be one of the goals, but we can still work to accomplish all the same things through the renewal letter process, for example.
Some of these tactics are just out there for us to scan.
Yeah, they're just more sample, Bill, just to highlight, goals and tactics. But the tactics are lined up with sample goals that are not the board's final goals. So I think just Ian can walk us through a fresh exercise around tactics. And if you guys have questions, you can ask. Maybe the goal slide is most helpful, Emily, to show. I don't think we have. It's more just a note slide left, so you guys can. That's printed page 59. You want the slide, Emily, that has the voted on goals?
Oh, the one we were just on.
Yeah, thank you. And if we need a little help getting started, you could rewind this morning's session. For those of you who brought member education forward, you had reasons that you brought it forward because you had specific examples in mind of things that weren't working. So then examples of tactics could be what are the things that we would do that would address those specific issues. For example, maybe in-person benefit Q&As from the carriers. Under member education, I think we also heard more language options came up, was mentioned as well. Just going from memory, we have notes also that you guys can think back to the morning and specific things that were talked about.
The renewal letters to the carriers due in early December?
Yeah, we'll send those out typically the end of the first week of December. December 8th comes to mind about, yeah. And those letters are all encompassing, just for the benefit of our new board members too. We ask about all the financials, the operational, the usual things, right? Like, look at the data you have and give us your first draft renewal increase. But then we also ask about, hey, these are the board's new goals for the next 2 years. And these are some ideas that they've had for accomplishing that. Tell us what you can do in this regard. If it's a little, if you prefer also, we can be a little flexible. I think the Mercer team was thinking we could do this as one big group. If it's more comfortable for you all, we are happy to split apart again. It doesn't have to be the same 3 groups, right? Like we can divide in half. I think just whatever makes people feel most comfortable and able to share ideas.
Okay, let's stay told, but let me, just for the new board members, just to repeat, in different words what we're talking about here. And for some of you, it might be a repeat here. So what we do in October, November, which is now, and in the first week of December when we get together, is give what we think are important tasks for the upcoming renewal bid that is going out, that we do annually, right? So this is the next set of cost changes that we'll be approving in May. But we give an initial set of goals, which is what we're working on right now, and then we'll clarify this at the first meeting in December as well, and talk about other tasks. But what that then generates is our negotiator team, which is Mercer, will put out a letter to our carriers saying these are what we want to see in our bids for this coming year. And then that's an initial start, and we'll get numbers back through Mercer on these kind of things that then we'll look at probably in March and say, okay, here's the response that we got from the carriers, and we might make adjustments to that. And then Mercer will come back with options like, well, if we drop this, add this, whatever, what we've been talking about, and we'll kind of discuss some preliminary thoughts in January and February, but then March we'll make some changes to that, and we'll get a second round bid from our carriers through our negotiating team, Mercer, right? That will then bring it back down, and we'll still be approaching the goal of our 3.4 and what the kind of coverages changes that we're asking for. And we'll get some, we'll not get some, some things will be a choice. There'll certainly be options that will come every year that will take us, all the options will go over 3.4. This is where we get into the hard choices, which things, and Mercer will come back and say, okay, here's their recommendations on different groups of options. Take options 1, 3, and 4, or take options 2 and 4, or take options 5, right? And then we'll look at that and we'll debate that here. And then it'll go out for a third round of bids, right? And then we'll come in May, which is our important meeting, this meeting and the May meeting, which is the final bid from the thing. So based on what we've given them feedback for, and we'll approve or make minor adjustments or make it conditional, which is also there. So for you new board members and some of you who have been around a while, I'm giving you the timeline of what's going to happen, which we do every year. This is an every year kind of thing. So what we're doing today is just setting those high overarching goals that we want in that letter to make sure that they're being addressed by our carriers in the opening round of bids. Questions on what I'm saying, especially from the new people? Right, two of you have experienced this, but didn't really. You came in right when the process was in the middle, right? So now you're here at the beginning, right? So let's talk about just that. You get that, or you can follow what's going to happen here, right? So Mercer is our contract thing to teach us about what's going on in the healthcare industry and be our negotiator team to our carriers, right? That's their role. So comments, questions? Yes.
I mean, if these are, okay, so these aren't just goals for us, they're goals that we want to propose to our carriers. So then growing OEB and exploring an RFP are not things we're sending to our carriers, that's stuff on.
Well, it can be, because they do communication as well to their people, right? So, but it's mostly what our marketing team is doing, right? So
This is it's like a mini RFP. We're really going out to bid to them and saying, this is what we're interested in. Please come back with proposals.
Mm-hmm.
And then we take that in. And
so we
the
could
process starts.
say in goal 3 in the mini RFP, like, and asking them what we want them to expand GLP-1 coverage, right? We can ask that.
We would ask them for the cost to expand
Yeah.
GLP-1 drug coverage.
it would be an option package, right?
Yeah.
Here's what this costs, here's what this costs, here's what this costs,
Yeah.
and we have to pick and choose without going over the 3.4%.
But just a point of clarification though, we do sometimes have goals. I'm thinking when we set goals in December of 2022, one of the goals was legislative influence, and that was more of an internal board goal that we all collectively had and you had, but we didn't ask the carriers to do anything about it.
Yeah.
So that could be true of
Like-
grow OEB and explore the RFP.
Yeah.
And then the other point of clarification is that I like Ali's, a mini RFP is a good way to think about the renewal process. That's just like the venue for making changes at renewal, right? It's just the process. We send the carriers the letter, we get the response, we bring it to you, we ask follow-up questions, we get the answer, we vote. That's just a process that's in place that we follow. And everything that we're doing here today is really just deciding what do we want to put into that process ahead of time. What are your guys' priorities for the renewal? We will plan, we already know we're going to ask some things that have been around since last year. We know we're going to come back to family building benefits and ask about adding artificial reproductive technology and some other things. We know we're going to ask about GLP-1 drug coverage, some benefits that have been on our radar now for a while. And then
Traditional health worker, maybe.
yeah, and then this conversation, so for example, a new one is reduce out-of-pocket costs. So we don't typically ask the carriers questions along those lines because we have a difficult time at renewal anyway. But you guys have circulated a lot of really excellent ideas today. And for example, if we're thinking creatively about reduce out-of-pocket costs, the topic that we're talking about with Ian around helping members understand that there's like, emergency department and then urgent care, and then they have in-office provider visits, and then they have CRSMD and Teladoc. And there is a cost order to those that is known and could be communicated. And that does directly lead to reduced out-of-pocket expenses, not in the same way that a lower deductible does, but in an affordable way to OEB, right? Like there wouldn't be a cost for that because the lower costs, pay for members to go that way.
And it also falls under member education, which everyone is going to do.
Yeah, it falls under member education. So, and we collectively call that idea site of care, is where you're going to go for care. So maybe some work that ties in with a lot of things we've been talking about is site of care.
So, and then how specific do you get in the instance, okay, so we're going to do site of care, and as OEB, we want to see that broken down by county, or, does it go, the goals go to that level, or do we leave that on Mercer to identify how that rolls out?
I think this is where the board asks Mercer.
Okay.
Hey, Mercer, it's important to us that we're looking at site of care utilization by region, but we agree with you, and any other metrics that you decide. Because we know, and something else I'm thinking as a result of all this conversation today is that I think a lot of the member education is looking at point solution utilization by region to inform us, hey, we know that all of our digital healthcare options have even more importance in rural Oregon, where there's an access shortage. So that's the first place to zoom in if we're thinking about a member education campaign, is looking at things by region, making sure we're messaging effectively, and then understanding, what are the barriers there.
So these kind of things we're talking about for the next 20 minutes, just giving extra guidance to our team on how we do this upcoming round of renewals.
I feel like there's been a lot of healthy conversation. I know you guys have a lot of stuff swimming in your brains about how we're feeling about things there.
So I would so our member education, you're saying the reduced out-of-pocket costs could be done through member education, right? So that maybe wraps something
One
in there,
tactic.
like one tactic, okay. I don't know why I had to clarify that. That has nothing to do with why I started talking. Member education, maybe one of the things that we specifically ask Moda and Kaiser in this is if they would be willing to offer to the, all the entities under OEB, right, to do in-person information sessions from them.
Could be even post or pre-renewal.
Yeah, no, what Erica mentioned, they do open enrollment, pre-enrollment fairs at something like 170 of the entities. It's like really impressive, but that's not the same thing as once you actually have your benefits, now you have usage questions.
Yeah, like how do you, all the questions we talked about in our meeting is, we have so many employees who just aren't tech savvy that are like, Sally, I don't, here, help, right? And I'm like, I got you. But again, there's me to over 1,000 classified employees, right? And I was thinking it would be really cool. It's kind of where that idea generated from, is if like Moda could come out and the Kaiser could come out and do like a presentation where employees are there and there are computers available of, okay, here's how you log into Moda, here's how you create an account, right? Here's how you access your member ID number, here's how you access all these different benefits, how to kind of navigate your dashboard. So we can also be there to kind of help people, along, understand, helping people figure out how to access their EOBs and understand them, all those sorts of things, like an in-person session. Because I do a million things over email and Zoom and all that sort of stuff, and I get out to schools, but for a lot of districts, they either don't have a benefits coordinator that can do that, or it's like my situation, there's one of me to over 1,000 classified employees. So, if we can host these like larger things where somebody from MODA there specifically is like walking them through and they know really the background of those platforms, that would be really cool. And again, the same with Kaiser, right? And like understanding the deeper pieces of your benefits. But if Kaiser and MODA themselves could kind of offer that as a service, so that the districts, or entities that are under OEB know that that's available as well, right?
That's a great topic.
I think,
I was gonna ask if you thought it'd be helpful also to add Canopy EAP.
Absolutely,
Since
yes.
it's new.
Yes,
and
thank you.
that's
Mm-hmm.
Something everybody can access as well.
Yeah.
I think under the member education, I think that's great, but I think that one of the things should be a diversification of the mode of communication for education. So here we have in person, but we also have the younger generation that if we gave them an app, they would go and find what they needed through technology, right? And so while the message is the same across all the platforms, we need to kind of do a triad approach of hit the generational where they are on how they want to communicate, right?
I think MODA has rolled out a
5 seconds
preliminary
is all
app.
you get.
And that's exactly what I was gonna say. If I listen to my high school kids, right, you got 5 seconds to convince me you're gonna answer your question and 60 seconds to answer my question, right? And so it'd have to be a series of short, exactly, this is what I wanna do. Give me a video that tells me exactly that.
Today, that
Right.
if you start looking at something, it can finish your sentence for you, and then pretty soon it starts shooting back to you pieces of data that it thinks you're trying to
I don't think MODA's app's using AI yet, right?
But
So,
it is there.
but yeah, I'm just saying MODA does have an app that they were just in prototyping last year, right?
Well, they have their main MODA, what do they call it? My MODA
365 or something like My MODA, right? Yeah.
Well,
And it
we're
guides you
becoming
through the
like-
process,
We're
right?
becoming isolationists, right? I want this information. I don't want it in a large group of people, and I want it on my timeline. So I hit that button and I get what I need.
And I think that's what MODA's app is designed to do.
Yeah, so
right?
I think that the component of OEB around that is important as well, and what the member benefits are and everything.
On top of that, though, we want to look at expanded language capabilities.
Mm-hmm.
Yeah, same.
Michelle.
I have to leave early, so I'm going to share just a couple of disjointed thoughts on this. One is I hope that we will keep the expansion of family building benefits front and center. It is an equity issue. It's part of reproductive health care. I worry about any changes where we're pushing members to apps and away from in-person interactions with healthcare providers, because it feels like it's a cheaper, it's a less valuable experience for the member, and yet we don't usually notice our costs going down along with that. We just get worse care sometimes. Like I would, just using the physical therapy app as an example, like I would love to have an app for physical therapy, but I also want the in-person, check in to make sure I'm, my form is right and everything. So, and then I like I noticed the telehealth units, like anything like that to increase access to care for our rural members seems really important. And I don't know if the mobile health units is the most is the best way of doing that, but I don't know if they would have other suggestions on how to improve our reach. Michelle, do you mind repeating the last thing that you said? I didn't hear who you were saying. Oh, the mobile health units, as a way to increase our, increase access for rural members. Yeah, I think that's kind of it. But I'm sorry, I do have to leave early.
Well, thanks so much.
Yeah, are you gonna be reporting out like what people are saying with
Yeah, I think it would be appropriate to send out a summary of the day and where we went at the end of the day. To you all. I know we talked about a lot. Yeah. Yeah, family building benefits certainly falls under, well, we can do it, doesn't have to be the call. It certainly ties in with access, equitable access.
Thoughts? Anybody else have any?
Specific things we want to accomplish, maybe board members who were here last renewal, things that we talked about that got tabled or we talked about in prior renewals, or things you're hearing from your members, more specific things.
So as far as number 5, reduce out-of-pocket costs, I mean, something the board has looked at in the past is maybe a narrower network kind of plan that's more PEB-like, that has lower deductibles, lower co-pays. I know the problem is it's not very equitable across the state when you look at those, but then you have to get the providers to go. But maybe the carriers got something cooking there. Yeah, definitely something to look at.
I guess this is not a goal, but maybe the carriers can throw down a 20-minute presentation each on where they see some ideas that they have are on that category, what they think is kind of not working well, and they're being asked to do it, but they would suggest something, from their point of view.
Usually in December or January, we have the carriers in to talk about innovations that they've been working on. We could steer that a little bit more and say, we want to hear about your innovations, but we also want to hear about anything you have that would do this and such. And then we give them a month to sort of prepare, and they bring folks in and they give us that. And that could be fertile ground for, we kind of like that idea. Can you add that to your list of things we asked you in the renewal letter and give us a price on it?
Yeah. There's also an aspect of the renewal letter that always asks, what other ideas do you have that we haven't asked about yet? So it's not so.
I just want to touch base on the goal number 2. I guess this is not only a Mercer or an Ali ask as a board. I mean, for example, with my members, there's more educator associations from across the state who are joining OEB. But I think in my perspective, it will be helpful for the school board association to help with the messaging. It's not just the local HR department or it's the local union president. I think it's a trifecta of leadership to help expand OEB, for example, Springfield or Beaverton, right? Or Portland. So I think maybe that should be a conversation sometime next year of what can we do with our relationships as a leadership group to talk to those levels of leadership and then expand that membership growth within OEB, because then at the end of the day, it gives us more leverage on the purchasing power within the healthcare provider. So I think it's more on the OEB board to leverage those relationships and provide them with, maybe we're the ones to go to those districts and give them a presentation why OEB board is awesome. This is being independent. And, like Ali was saying in the last meeting, people are getting priced out. So I think that's on all of us here. So it's not on staff much. So it's because we're here in this role. So I want to put that on the road.
And just so the new members know, we do have a licensed sales agent as part of our staff, who's a former broker. So if you guys can get the door open for us to get in there, then we can actually come in, take a look at their benefits, give them some financials to take a look at and start the whole sales process. That's a position we added 3 years ago, I think. Georgiana's been bringing in a lot of our business. It's a long process. OEB's old reputation wasn't stellar out there with a lot of entities. We've been working really hard to improve that with things like the OEB advisory group and just Georgiana's work in the field. So yeah, any doors you can knock on or get people willing to listen, that's the kind of entree that we could really use to help grow.
Have you ever presented at like a COSA superintendent off the record meeting or OSBA, those types of things?
Georgiana's been to several entity meetings. I think OSBA, there was one in Central Oregon. I'm not remembering which one it was.
So
yes,
yes,
open to doing that. It's about creating a little bit of spark of interest and then the follow-up conversations. Because there's always politics that you have to deal with eventually, whether they're up front, in the middle, at the end, or all throughout.
Yeah, if I could just add to what Damien said, also just remember for local government representatives, that local governments, of course, can participate in OEB, and that's actually a big area where, you know, in comparison to the number of districts that are participating, but local governments, that's a big area of, I guess, fertile area where we do need more participation. So if you know, within your jobs or if you know of organizations that you would, suggest that Georgianne or you could open the door with, that would be great.
Have you guys ever been to Association of Counties?
I'll check with Georgianne.
Yeah, because we have a Association of Counties meeting coming up here in November. It'd be a lovely place for her to.
The CIS rep will be there if you.
I know they
so
will be,
right,
because they're
right. I'm just saying,
a fair amount of speaking on the HR side of things, right? But
I've been down that
they're a
road.
risk, right?
Yeah.
But
Yeah.
I know that their stuff is expensive. We had meetings on multiple occasions because some people of our team members say they want to switch over, just like, for like a double-digit increase.
I've gone down this path with League of Cities, right?
Yeah,
And
yeah.
it's been a challenge, right?
Yeah,
But
it's still options that they should hear.
Yeah. Oh, no question. And they do hear, right?
Okay.
Because I'm in League of Cities, right? So, as for OSBA, just to clarify, for the school boards we do contract negotiation and budget only on the portion that is paid by the district. We don't have any say as school board members on plans and stuff. That's really a COSA thing.
Yeah,
right?
but at OSBA, there's tons of superintendents that are going to those sessions.
Yeah, so we work with Morgan, to go through that kind of stuff. And Morgan really is our access point for that, right? But back to you, I've done projects with Gustavo out of Beaverton in the past, so I'll gladly smile, show up at Gustavo's office, right? And chat. Gustavo and I have some history. So.
Yeah, from our perspective, we're not out there direct marketing, but we do think it's fiscally responsible to look at your options. And before Georgianne, we didn't really have that kind of person out there that
as a board member, I didn't really feel empowered to reach out to these people and say, hey, I did with Don because we were friends, right? But but if I am empowered, I'm happy to do it.
Yeah, I'll start poking.
I'll
poke Gus.
But I have reached out at League of Cities and with
OCC is another one.
Yeah.
We just had a great conference with them.
Yeah, the CIS guy always follows me around
Yeah.
everywhere I'm walking.
I'm sure.
Right?
I'm sure.
So,
I'm sure. I mean,
Yeah.
but they're expensive.
Yeah, but there's just a lot of misunderstanding and misperceptions going on there. Go ahead.
So back to kind of like my couple points I already said was asking the OEB and Kaiser to make themselves available, expanding GLP-1 coverage, but provide equitable access to affordable care. I'd like to see Kaiser maybe explore how they can expand coverage in more rural areas. And if they can like slowly continue to make those contracts, I think more and more people will sign up for them, which will allow them to expand more and then build more Kaiser facilities, right? So I think it's,
More choice.
yeah, and then it opens up a lot of those rural areas to, for it making sense for them to have Kaiser as a plan that they offer if they don't already, and then gives those employees access to a really affordable, low-cost plan. And then the RFP, our initial kind of conversation about that was the kind of purpose of that was to look at other carriers and do a comparison and kind of see, you know, if we want to, in the future, if a change makes sense for any of our carrier options now. That's my cap.
Thank you, that's great.
As well.
Well, why don't we talk about some wrap up then? I'll point to you two, say which one you two want to go first, or want to draw straws or flip a coin. Hey, you want to wrap things up?
I feel like Ali should be the final closeout, the final word.
I didn't know, do you want to go first then, and let Ali finish?
Yeah, let's close on Ali. That sounds nice. I think first I would just like to say thank you all for coming and being here and sitting at the table with us all day talking about health insurance. So we get it, for sure. And we really appreciate your insights. You know, at the end of the day, you guys provide the missing link to all of it, right? Which is that you are connected to your members in a way that we can never be, even though we read surveys and we know a lot about health insurance and healthcare as well. At the end of the day, we can't meet the needs of the OEB members if we don't know about the OEB members, and that's really what we rely on you for. And thank you for all of your work today, participating, sharing member insights and frustrations, and helping arrive at a really exciting set of new goals. So they're really different from goals that we've had before. That's going to be fun. I think it reflects the new personality of the board, and along those lines, it's been really great to get to know you all and meet you today. We often say we wish we got to see you in person more than once or twice a year, because it might be until April before we see you again, but it's certainly just been nice to come today. Have a safe travel home.
Thank you.
Well, just like Kirsten said, huge investment of your time today. We couldn't thank you enough. I think, you know, spending time like this for us as staff and Mercer is so valuable, and especially getting to know new board members. We're excited about, you know, new fresh perspectives, new contacts around the state. As I talked about at the beginning, I think there's a lot to be proud of with OEB right now, but at the same time, there's a lot to improve, to really be responsive to our members, and you know, we want you to be able to carry a positive message, but we also want you to carry messages of unhappiness and improvement back to us. That's how we can really serve the board best, and so please don't ever hesitate to do that. That's what we're here for. Every staff member has an open door, so feel free to contact any of us at any time. And, have a great rest of November, and we'll find out what our renewal rate is, where we're going to start. What, January?
We'll first hear in February. February 4th, we'll see that one.
Great.
And I'll finish again, also thanking the board members, welcoming the new board members. Thanks for joining. Dr. Laura online. I don't know about you, but this was way better for me than sitting in a room with a TV today. So I was happy to be here. Of course, we're going home and there's a TV at home. So, but yeah, this was important goal setting. Really nice to get a lot of new input. Really nice to get the input from our Mercer team and staff here at OHA. Appreciate all the candidness and the openness and the different diversity of input that we get from all our board members is really important. And we should be doing the good thing. And just want to reemphasize the important work that we're doing here for our 40,000+ members. 150,000 total covered. This is important work for a whole lot of people in this state.
Budget.
Yeah. So, how we deliver healthcare and improves people's lives. This is important work, and I'm happy we're all part of it. So thanks again for coming. I would like to say, who would like more in-person meetings? Right, we do two. I've been leaning on Ali to say we should do more in-person meetings. They'll be hybrid if you can't make it, right? But
Problem is when you're at your local space, people find you in my way.
Yeah.
I can't focus like this is much more productive for me.
yeah, but at a minimum, I was hoping we could do like every other meeting would be an in-person meeting, including the ones in May, of course, which are the important ones when we're approving the final package. Those will always be in person, and so will the retreat. Those two are automatic. But just coming together and if you see the carriers in person and get to shake their hands and things, that's a big deal, right? I know it's very important for me. It took me 3 months just to realize who was Kaiser and who was Moda when I first joined this board, right? So and it's important just to have hallway just casual conversations with our carriers. You really get to know them personally. It's quite important. But anyhow, thanks for that input. Again, thanks for coming today. We appreciate it. See you next time. Okay.
And Susan, I didn't mean by you, not just by you. All of a sudden, it shows me over my 40 hours.
Just hit the microphone button there, so it turns red.
So this is a major time.